Lobule positioning. Correction of the lobule during otoplasty continues to represent a challenge. The lack of skeletal elements within the lobule makes controlled repositioning of the lobule more difficult and less predictable. The initial problem analysis prior to otoplasty frequently shows a marked anterolateral projection of the lobule. Following antihelix plasty, the lobule often appears to protrude even further. Novice surgeons may not realize this, and the final result can be compromised as the ear sits back to a normal position but the lobe remains protruded. For aesthetic reasons, the lobule should be positioned parallel to plane of the upper third of the ear, and a lobule mastoid angle greater than 40 degrees has been documented as excessive. Earlobe is somewhat separate from the mainframe of the auricle, but it is not less important for a pleasing result. The cause of the lobe protrusion can be related to a protrusive or hyperplastic cartilaginous cauda helix, the tail of the helix. Awareness of the appropriate relationship between the lobule and the helix/concus architecture is an important element in successful otoplasty, as evidenced by telephone ear or reverse telephone ear deformities that often result when the lobule is not adequately managed. A fishtail skin excision is a simple technique to set back the lobe that utilizes triangular excision of skin on the posterior lobe and a corresponding excision over the mastoid region. Removing lobe and mastoid skin in this configuration enables the lobe to be tacked to the mastoid skin and heals in a more retrusive position. Gossain described an approach to correct the prominent lobule during otoplasty. His technique utilizes a small incision extending laterally from the primary otoplasty incision, which permits exact positioning of the lobule. The lobule is then supported by a single suture from the skin to mastoid fascia. Wood-Smith suggested a fishtail-like retrolobular skin excision followed by VY-plasty. This technique allows for the adjustment of the vertical height of the lobule as desired, with suturing 0.4 to a higher point, offering potential permanence by suturing the superior part of the helical tail, 0.4, to the conchal cartilage. Batuhan, 2024, used vertically extending fishtail excision starting from the inferior end of the otoplasty elliptical excision. An important point is to maintain a limited horizontal width for the fishtail excision borders to prevent the appearance of a narrowed and bulky lobule on lateral view. Additionally, the incision must be completed at least 0.5 cm above the lowest border of the lobule to ensure the scar remains discrete. Spira et al. Treat the protruding lobule by wedge excision and a deep dermis to scalp periosteum suture. This approach may provide long-term durability, but may cause complications such as hematoma due to the necessary dissection of the mastoid region. Lobule correction in otoplasty using fillet technique. A. Suture dissection and transection of the lobular soft tissue insertions via the fillet technique. The extent of this dissection may be modified intraoperatively as dictated by the deformity. B. After dissection, the anterior and posterior surfaces of the lobule may move and advance freely in relation to each other. C. Advancement of the posterior flap allows for correction of angular protrusion in both the axial and the coronal plane by anterior to posterior and superior to inferior advancement, respectively. Inferior to superior advancement also allows for effective correction of lobular concavity. A horizontal Y shape was marked on the posterior surface of the lobule, so that the arms of the Y pointed the lateral edge of the lobule and the foot pointed the direction of medialization. The triangular flap formed between the arms of the Y-shaped incision was advanced medially toward the mastoid and held at the tip of the foot of the Y-shaped incision. At this stage, the new position of the lobule is checked and the incision may be elongated medially if further medialization is necessary. Tips. Numerous descriptions of the surgical correction for the protruding auricle stop after cartilage realignment and seem to assume that antihelixplasty is identical to otopexy, which is definitely incorrect. As stated earlier, the lobule should rest in a straight line with the helical cartilage when viewed from the front. The correction of the lobule has often been treated with less regard. Bierning, in a study of 159 ears, stated antihelical correction corrected an associated protruding lobule in 28% of patients. Combined techniques. There have been countless descriptions by individual surgeons detailing their particular combination of the above techniques to effect reproducible results. An ear with a deep concus but well-developed antihelical fold may only require a conchal resection, with the addition of a conchal setback if the conchal-cephalic angle is greater than 90 degrees. A poorly developed antihelical fold will be present with or without a deep concus. In this case, mustard-type sutures should be used to create the fold. Anterior cartilage scratching should be used as an adjunct to help fold the cartilage. Superior pole overcorrection should be considered because this area is prone to recurrence. A prominent lobule not corrected by finger pressure on the helix rim will require one of the previously described additional procedures. Posterior scratching is contraindicated because it results in cartilage bending in the opposite rather than the desired direction. Likewise, through-and-through cartilage incisions should be avoided because of the resultant visible step-off deformity. Pearls. The keystone of the auricle is its strongest part, where the helix, antihelix, and antitragus join, which holds the auricle in the position of protrusion. This is the point where the cartilage of the auricle has to be cut. Since the antitragal muscle reinforces this keystone, it has to be excised, too. The keystone of the auricle could be compared to the cross brace in a kite. If we should break it, the kite would collapse. For the same purpose, we perform a horizontal incision of the cartilage between the antitragus and antihelix just above the fissura antitragicohelicina into the concus for a length of 10 to 12 mm. This will take the spring out of the ear cartilage, thus breaking the architectural integrity of the auricle. Stenstrom suggested deepening the clefts between the tail of the helix and the concus with an incision that slants toward the crus of the helix. Davis removes a triangular fragment of cartilage between the helix and antitragus. To conclude, management of the lobule in cosmetic otoplasty can be easily overshadowed by management of the more cephalic anatomic causes of pромenoris. Despite being less studied than those causes, the surgeon has multiple approaches to the lobule available. Otherwise perfectly undertaken otoplasty will still yield poor results if the caudal ear is neglected. The Negraverne otoplasty technique. The Negraverne otoplasty technique is a simple method of cartilage weakening mainly preferred in young children. In this technique, the cartilage under the desired fold is marked by inserting dental needles at 2 or 3 points from anterior to posterior fashion. The inserted needles mark the lines of cartilage weakening. The monopolar diathermy is adjusted to a setting sufficient to create a partial thickness trough through the cartilage. 3 passes are made to form the antihelical fold while maintaining sufficient flexibility to prevent a sharp angle at the fold. Next, the conchal hypertrophy component is addressed. The marked conchal limits are used to mark proposed conchal scoring incisions, which are parallel the long axis of the ear. 2 or 3 incisions are made with a monopolar diathermy. Minimally invasive otoplasty.